McCall, honey, how are you doing today?
I am so good. I'm so happy to hang out with you. Thanks for having me.
Oh my gosh, it is such a pleasure. I just love you so much. And I know we were talking right before we got started just about our journeys. I know we both have thyroid journeys. And I was curious to hear if you look phenomenal, gorgeous, youthful, all the things. And I know that a lot of my friends are in the peri realm, but I even had to ask, I'm like, are you even in perimenopause yet? And I would love for you to answer that. And how's your journey been so far?
It's hard, as I shared with you. I had a uterine ablation, which means I had the lining of my uterus ablated, removed. So I no longer have a period. So I don't have clarity on, hey, how frequently am I having cycles? Is it every 28 days or so? So I don't have a ton of clarity on that. But what I do have is over the last several years, right? I have had significant symptoms of low progesterone, right? I'm sure you talk a lot about that anxiety, that edgy, that agitation that we start to feel as women either with hormone imbalances or perimenopause. And then, of course, like all the classic low T symptoms. And just in the last maybe 6 months, I've started to have a little bit of low estrogen symptoms that I'm picking up on. It like everyone, it can be a little bit of a gray area, the perimenopause phase. So I'm so happy you're bringing all of these discussions to light to offer so much clarity and support for all of us women navigating this.
Oh, no, absolutely. Well, I'm so grateful that you are out there taking care of so many women in this particular time and transition. And that's really what I wanted to converse about today was even in the realm of thyroid function, one of the things that I'm seeing is that women are coming in, maybe they didn't even know they had low thyroid function yet. The symptoms were just kind of still under the hood, or it
Mhm.
felt like the everyday pain points of life. But then they get into perimenopause. I don't know if it's the declining of the reproductive hormones or if it's the stress that feels a little bit more overwhelming, or the fact that I think of perimenopause as a bit of a default inflammatory state due to
Mm,
the uncoupling of these hormones. And that as a
mhm.
result, we start to see this kind of uptick in antibodies, whether it's Hashimoto's or whatever. And so I was curious looking at even maybe women that you've been taking care of in a timeline
Mhm.
where maybe they're
Yeah.
in their 30s and then they're into their 40s and all of a sudden more things start to pop up. I'm just curious to me, what are you seeing in practice?
I would say it is a pretty big shock to me if I meet a woman in their 40s, especially one that has kids and they don't have a thyroid problem. Like, I think by the time you're hitting perimenopause, you really need to be screening yourself annually in an in depth manner because most likely you have a thyroid issue. I do see antibodies kind of wax and wane in mid 30s, I would say to mid 40s is probably a pattern that I've seen in my practice. And then research really shows there's a huge uptick in hypothyroidism, not necessarily Hashi, during menopause. And that's like the time stamp where they start to look at studies because it is finite. Sadly, again, these women going through perimenopause are kind of left in the dark. Studies aren't really being done in women in general, but especially in the realm of perimenopause. Again, it's up to us almost to advocate for ourselves, to look deeper, to find answers, especially if you are having those thyroid symptoms, the classic ones that so many women struggle with and write off and even kind of get written off from their doctors.
I would love for you. We're going to take it a major step back and talk a little bit about what are those most general low thyroid symptoms, because they can look, when you run them against perimenopausal symptoms, they look so identical, but there are obviously some that very much follow the pattern of low thyroid.
There's definitely some overlap,
Yeah.
especially like the testosterone piece, even more. But it's the fatigue, it's brain fog, it's weight gain, it's hair loss, it's raises in blood sugar, poor metabolic function, low sex drive. And you guys, I mean, I can overlap those with perimenopause, but definitely very, very common. And the problem with medicine is they tend to say these are just very general symptoms. A lot of people have these. It doesn't mean anything's wrong. No, like both thyroid and perimenopause hormone dysfunction are two things that can very readily be addressed and fixed in so many women. It's not something to just blow off and live with.
Agreed. Well, in mine were, I lost my eyebrows girl, I never got them back. Let me tell you, constipation, cold
Yeah.
hands and feet. Those are
Yep.
big ones for me. My hair did not either.
You
I
have
didn't
beautiful
notice
hair.
it and it didn't get brittle. I didn't start to lose
Yeah.
it. That wasn't a sign for me. Nails and skin didn't really change as well,
Mhm.
but definitely metabolic. The weight was big. And for me, it ran in tandem with estrogen dominance.
Yeah.
So
It so often
yeah,
does.
I was going to say so many times you're like, oh, is this is this estrogen dominance? Is it low thyroid? I'm like, it's a yes and.
It is like when you have low functioning thyroid, you start to lose progesterone, testosterone so early on in that process. And I always describe like the balance between progesterone and estrogen, like that seesaw. Once you lose that progesterone and it gets tilted and estrogen's too heavy, it's so hard to fix that balance without having support, without having some kind of an override mechanism where you can create that balance again. And then a lot of people can maintain it. But again, in perimenopause, that seesaw, it is swinging and it needs a lot of attention.
It needs a lot of attention. It needs a lot of titrating. I always
Mhm.
tell women that what you're doing at 41, 42, 43 is going to look a lot different than 45, 46. It's going to look a lot different than 48, 49. And this is definitely the time to be open to change and pivot. How I was addressing this at 42, 43 is there's some foundations that haven't shifted. There are some things that I feel like you're going to have locked and loaded. But in terms of titrating, supplementing hormones, making sure thyroid is dialed, making sure I take thyroid hormone, I take Armor through you, making sure that that is dialed. I know that all of those things can shift and change. And I'm open to making sure that I'm staying on top of that because as I move through the perimenopause journey, I feel like it's a mixed bag.
And you need that care team in place before you hit that phase because it is such a confusing thing to navigate and it needs constant attention, titration when you're having these swings. You don't want to be trying to figure out your care team then. Ideally, you do it kind of before leading up to that time or as early in the process as possible. You have those people who have your back that can support you through it.
I 100% agree. I absolutely wholeheartedly. I want to go to labs really quickly. Most women in their and I'm advocating a physical and full labs every single year at least. And what you and I both see when I get initial labs from somebody, they send them on over. I'll see a thyroid stimulating hormone lab. Maybe I'll see a T4, free T4, and that's it. And it doesn't give me, I mean, it gives me enough information to say we need more information, is really what it does. And tell me when women are advocating for themselves, and I have a full list that I want women to run. I know you do too, but just on the thyroid perspective, we want to please run through those. And then are there other ancillary labs that you're like, these are non-negotiable for me to
Mhm.
see along with these thyroid labs?
I mean, in women in
Mhm.
their 40s, 50s, headed into perimenopause, in perimenopause, absolutely you need a full thyroid panel, which can snag a pen and paper, but it is TSH, it's thyroid stimulating hormone. It's free T4, which is your inactive hormone. Those two are often ran. They do not in any way give someone a full picture of what's happening with your thyroid. So never stop there, especially not if you're symptomatic. You also need free T3. That is your active hormone. It is what drives our hair, our skin, our metabolism, our mood, our cognition, our energy, at least in some forms. You need reverse T3, which is an inhibitory hormone. If all those things look great and your reverse T3 is skyrocketing, guess what? You still have thyroid symptoms. If no one's checking, you'll never know. And then I very much, like you mentioned earlier, these women need to be worked up for autoimmune diseases. Women especially are at risk for autoimmune diseases, and we need to be screened for Hashimoto's with two antibodies, which are called TPO, thyroid peroxidase antibodies, and thyroglobulin antibodies. And that's like bare minimum, like thyroid function testing. But I really think women need to look deeper in this phase of life. And we need hormones, of course, like estradiol, progesterone, testosterone, sex hormone binding globulin, how your hormones are transported, moved, DHEA sulfate, and adrenal hormone. And then I like to do a deep dive on metabolic function too. We are in a pivotal season of metabolic shift in our 40s and perimenopause states. And so I look at leptin, fasting insulin, fasting leptin as well, hemoglobin A1C. That's all like a thorough in-depth metabolic panel. I also like to check HSCRP, inflammatory markers, an in-depth lipid panel that looks also your HDL, LDL, cholesterol, triglycerides, but also your VLDL. We want to look a little bit deeper, kidney function, liver function. Those are all basic things that any doctor will run, but most people never get their fasting insulin checked. It's
No,
one of the
it's
biggest
heartbreaking.
long-term health markers.
And even with your fasting insulin, you're going to see a range that goes from
Mhm.
1 to 25. That's normal. And it's not normal. I want to see your fasting insulin below 5 or below. is my sweet spot. Other labs that I like looking at too, because this was an issue for me, and obviously I'm not basing it on my own personal experience, but based on what I see, is I want to see a vitamin D lab, because every woman, but especially a woman with low thyroid function, it's always either it's the lowest of the low or below the low, below 30. And then I often run a full iron panel too, just to look at ferritin,
Yep.
iron. Yeah. And I'm trying to think about what else, but those are the big ones. And then if I can get it, I'll do an ApoB, a lipoprotein little a, if I can get it.
Right. I know. I feel like they're making it harder and harder. They're really, even with D, like I'm getting
Oh
vitamin
yeah.
D
I
rejected by
one
insurance
time,
all day, every day.
yeah, they'll say you had it run this year. Like, I don't know if insurance is going to cover it. Or even my reverse T3, I'll have to pay out of pocket for. And homocysteine and fibrinogen, those are things. But even asking my patients to go in, I mean, not that I can't run them, but I'm like, hey, if you're paying for insurance, see what you can do. And then if you can't, then we can run them. But it's funny, the wheeling and dealing of getting labs done, especially even a
Totally.
fasting insulin that is inexpensive. But I really appreciate
Vitamin
that.
D is like
Yeah.
$16, but if patient's insurance rejects it, it's 500. You
Yeah,
know,
it's so
it's
crazy.
strange.
I don't want to belabor the outrage that I feel about this, but I wanted you to share because it's a comprehensive review of everything, especially if your thyroid function is low, whether it's due to Hashimoto's or it's a liver or gut issue or whatever, all the things in between. Yes, and note that it has such a profound impact on your metabolic health that we're going to need to see those numbers too. One of the symptoms of low thyroid function, and I think even of just perimenopause, is going to be that redistribution of weight from our booty and hips and thighs to our stomach. And that's probably when women are like, hard stop. I could deal with the brain fog. I was maybe okay with me being on the edge with my anger and rage, but you're telling me I got to put on some weight in a place that I don't want it. And then that's where I find women, they're like, listen, this belly fat, I'm not doing this. And this is when they'll come to me. And I know this is when they're coming to you as well. And I know that it's very much a comprehensive solution. Have you seen any, besides obviously perimenopause being its thing and thyroid issues being their thing, any other kind of red flags around belly fat that you are looking at?
Increased visceral fat, which is so often what that belly fat is. And that means like fat deposited on your vital organs is directly correlated with higher morbidity, higher mortality, earlier death, poorer life prognosis. I mean, it is a core measurement in medicine. It's dangerous. If we want to look at health risks, increases in that midsection fat are definitely one. And the fact that we've normalized that for women in medicine, in perimenopause and menopause is not okay, right? We need to address all of those factors, whether it's inflammation, whether it's thyroid, whether it's hormone changes. We want to, again, hit this early on so that we can prevent those poor outcomes in our health that even though they're common, should not be normal.
No, should not be normal. Absolutely not. And you said it's one of those things that I'm just like, it is unnecessary. I'm not doing it. And I want to talk a little bit about what you are doing in your practice around the body composition changes that are happening in midlife. And I mean, obviously dialing thyroid hormone is going to be really important, especially if that's one of the root causes of that shift in fat redistribution. That may not be enough. Obviously, lifestyle is a big player here. That should be foundational. But I'm curious to hear a little bit about what your strategy is for navigating that extra weight, that metabolic change, and what kind of success are you guys having?
I think this is such an important conversation for women because so many of us have been cast aside and have just been told, well, hey, you have this weight, eat less and exercise more, and that'll do it. And that is really not the case. I mean, there are millions of women who are eating ridiculously well and exercising ridiculously often, and they are not able to influence their weight, especially not that fat around the midsection that is so damaging to our health. And we ran into this issue at Modern Thyroid Clinic where, hey, we'd perfect people's thyroid. We'd perfect their lifestyle. They were in it to win it, working hard, and they could not lose weight. And several years ago, when GLP-1s early on started coming out for weight loss, not just for the treatment of diabetes, I dug in deep to that research and we started a program at Modern Thyroid Clinic for that category of people that until now had kind of just been disregarded and unaddressed. And we have had incredibly profound impacts with our weight loss program. So impactful. Now we are launching a nationwide version of our program called Modern Weight Loss that launches this month. And not only have we been able to reverse insulin resistance, reverse leptin resistance, fix prediabetes, but we have been able to heal these women's metabolism and make them able to successfully come off of GLP-1s, continue to live a healthy lifestyle. And instead of not seeing the return on their investment, not seeing, being unable to maintain their weight with proper exercise and nutrition, now they can. So many people in our program are able to continue to lose weight despite stopping the program once their metabolic function is healed. And a lot goes into looking at that. And that's just one aspect. In my opinion, the weight loss from our program with GLP-1s is like an added bonus. There's so much further, deeper healing that's happening with these women that has just blown my mind and excited me about medicine more than anything has since thyroid.
I love that. Well, yeah, I want to explore that a little bit. One of the things that I've seen in the literature is the reduction in inflammation, particularly brain inflammation. And I'll see that in highly sensitive CRP levels. I'll see that in symptom, alleviation. I'm not sure if this is something that you're also seeing as a kind of a side benefit. I don't know if you're even treating women specifically just to reduce inflammation with GLP-1s.
I mean, honestly, I consider our practice to be so far ahead of the game in this topic. Like, one thing that we do well at Modern Thyroid Clinic is we collect data. Like, we mine for a lot of data. So the studies I was seeing a year ago, even, were looking at inflammatory markers after a year, HSCRP, which is that inflammatory marker. It also risk stratifies. It tells us about your risk for heart attack or stroke in the future. So it looks at things in a couple different ways. Well, we've been tracking CRP every 6 to 12 weeks from the beginning for 2.5 years now. And I've got to tell you a couple of fascinating stories about inflammation in particular. But within the last month, I had a patient check her CRP on June 26th, and it was 9.7. Okay. She did one microdose of a GLP injection with our program and checked her CRP the next week. Off meds, one injection, microdose, checks it that same week. Her CRP was like 4.2 in 7 days. And a microdose of a GLP. I've seen someone's CRP that has been my patient for almost a decade be 35 and go down to 9 in a matter of weeks. I have one patient who went on a trip to Mexico. I love this patient. She's one of my faves. Was doing so well, thriving. Went to Mexico, got some infection there, and came home radically inflamed. And when I say radically, I mean she flew all over the country, went to Stanford, went to Mayo, did EBO2 treatment, did anything she could, was miserable. It took her an hour and a half to get out of bed every morning. Her joints were so bad. The only answer was methotrexate and immunosuppressive. I'm like, listen, before you do that, I want you to do a microdose of a GLP. She didn't need to lose weight. Did it within 24 hours. Her inflammation was reduced by 95% subjectively, meaning she could feel that inflammatory reduction. Like, she got her life back in 24 hours. And those are not the manifestations in research for Alzheimer's dementia, but that's just another method of inflammation. It's neuroinflammation, and GLP-1s themselves impact inflammation in, I think I found 4 different pathways in research, none of which have to do with weight loss. These things are happening long before people are losing weight. And that's a message I want people to understand. This is not, oh, they're losing weight, so they're less inflamed. No, this is happening in hours, days after an injection.
I know, I ended up having a brain injury last summer, post-concussion syndrome, and it was a very dark time and my brain was very rattled by it. And I remember talking to Dr. Tina Moore, who's on this as well. I think you may have kicked off the program, and I didn't realize you just don't know what someone's doing yet. And so I was talking to Tina, and I was kind of a month into all the brain treatments, like hyperbaric oxygen, brain retraining. I was doing all kinds of things. And she sent me the literature around GLP-1s and lowering brain inflammation. And she's like, give this a try. And so it wasn't it was a bigger dose than a micro dose, but I did it for, I want to say 6 weeks, something like that. And at the time, my highly sensitive CRP was 1.8, girl. I was freaking out. Okay. I was like, I've never seen it even on the radar. I was like, I'm willing to do anything. I just might, when you're used to your numbers being as they are for so long and you start to see a shift, and you obviously know that there was a reason for it. I was on it for 6 weeks or so, or maybe it was up 2 months, like September, October. And that, of all the things, I did a lot of stuff, but of all the things I had done to get my brain right, to get it back to functioning, that was one of the biggest levers that I pulled, was bringing GLP-1s in.
There's nothing I've ever seen in medicine that compares from an anti-inflammatory perspective to a GLP-1. There's no lifestyle intervention. There's no medication. There's nothing that I have ever seen, truthfully, that remotely compares to a GLP-1 in terms of the reduction in inflammation. It's incredibly powerful, and I think it will forever change medicine moving forward. We're just beginning to scratch the surface.
It's just so incredible. And I want to talk a little bit about dosing for a moment, because obviously you go to your standard GP, they've got their dosing methodology. It's pretty much cookie cutter from what I can
Mhm.
gather. But I'm seeing, and not everybody, again, your practice and some small, some practices scattered along the states where they're really playing with microdosing GLP-1 agonists. And can you speak into what are some of the benefits of that? I mean, obviously, I know people are using it as a biohacking tool, they're cycling it on and off. Maybe they'll do it for 3 months and then take a break and bring it back on. So I'm curious. I just would love to hear a little bit about the philosophy around microdosing it in your practice, and what are some of the things that you're seeing? What are the type of strategies are you guys implementing?
I uniquely, I think, honestly, we've been one of the progressive programs that have been around for the longest. I started this so early on in this process, and I had never heard of microdosing before we started doing it. It wasn't a thing, and we sort of arrived at it quite naturally. But the rationale behind it is, look, like, we're setting dosage for the masses based on diabetes, people with
Yes.
diabetes, and people that are trying to lose weight, they're trying to reduce inflammation, they're trying to rehab their metabolism. They do not need the equivalent doses of diabetics, nor do we need to be increasing people in terms of doses every 4 weeks in the same methodology as diabetics. We started out with a very standard dose at Modern Thyroid Clinic in our program and quickly found out that a lot of people were getting sick. They were having side effects. And I would start to split their doses and have them do half twice a week. And then I would try to reduce that further and found that they did really well. And then I'd reduce it further. And we sort of happenstance arrived at this dosage of, wow, people are responding so much better on these smaller incremental doses. And then that led to people are not needing to increase these doses every 4 weeks. It's effective much longer than 4 week periods. And then towards the end of our program, when someone wants to come off of the medication or hit a maintenance dose, we would start to reduce them to figure out, hey, what is the lowest possible dose that these people can do well on, maintain their benefits of the medication without continuing to lose weight, and figured it was extremely small doses, not even every week. We've ended up now at our approach, honestly, at Modern Weight Loss and Modern Thyroid Clinic is people need unique dosing. Like, the reason people are having side effects is they are over medicated. They're increasing their dose too much. We're having a one size fits all approach. And also everyone's kind of left to their own devices. I mean, you see there's so many programs online that just send people a bunch of medication and everyone's winging it. And that is why these meds are getting a bad rap. People are taking too much. They're not being adequately supervised and supported. And our approach to that is like literally 180-degree opposite. We want very tailored doses and only the smallest possible amount that is effective.
Let's talk a little bit about how we kind of determine that. Like, what would someone be looking for in their own journey? Let's say they come to you and they're saying, okay, one, my metabolic labs are shifting. You know, that
Mhm.
begins as estradiol and progesterone both drop, even testosterone, all of this. We start to see those types of things going, still metabolically doing great, but again, a shift.
Mhm.
And then the weight distribution is happening as well. It's an extra 5 pounds, an extra 10 pounds, but they just realize that things are shifting and changing. And I obviously, I want you to share, but trying to figure out that smallest dose is going to be effective. Are
Mhm.
you guys starting small and then obviously reaching, talking with them and seeing any type of side effects? What are side effects that people could be considering? Like, for instance, when I was wearing it, I was tracking my glucose at the same time. So
Yeah.
I was wearing a CGM just to kind of see, and obviously like any type of symptoms that were going on. Initially, it was too big of a dose. Like, it majorly
Mhm.
suppressed my appetite. Majorly, that was the big one for me. I was like, oh, it's probably too much. I'm just curious, kind of what are you looking for? Like, if someone is kind of thinking about it, or maybe they're working with another practitioner or they're heading into that direction, what are things that they should be looking for to know that they're being overdosed?
I mean, it's interesting. So at this point, we hardly have any side effects. I mean, we might have 20% of people that have a little uptick in fatigue, which is extremely common, but like nausea, vomiting, GI issues. I mean, we've never had a single serious side effect in our program at all. But even the more mild ones dissipate. What I would say for people in other programs, definitely nausea, significant constipation, diarrhea, vomiting, I think is so wildly like a red flag for over medication. But the more subdued things that I think that people are missing, you should be able to eat food. Like, you should get enough nutrients. You should be able to get enough protein in. You should be able to eat enough micronutrients. If you cannot, you're over medicated. And that is why people are losing muscle, right? If you don't eat food and you don't move your body, because you're too tired and over medicated on a GLP-1, you're going to lose collagen and you're going to lose muscle and you're going to lose your hair. But if you can eat enough food and you can move your body, these side effects that people think are just endogenously from GLP-1 medications are actually not at all. They're simply from malnutrition because people are taking too much. And it shouldn't be a race to weight loss. It needs to be a sustainable health promoting healthy habit forming experience so that long term you're set up for success and you're not just trying to simply lose as much weight as quickly as possible, because that is where things happen. And then I think also too, if someone is giving you a prescription and then they're not ever following up with you and you don't have support for questions, dosing changes, nutrition, it's a good sign you're in the wrong program as well.
That's a great, I really appreciate that advice. Is there any considerations for, let's say someone's coming, it's the full workup, right? They have a thyroid issue, maybe it's even Hashimoto's thyroiditis, and their metabolic system needs a little bit of support, right? They need to optimize their metabolic health. Are there special considerations in that realm where someone is on like a desiccated thyroid medication and they're going to be on a GLP-1, just anything around along that line?
That's such a good question for so many people. A couple things that I've seen. Well, one, that's something I haven't shared with you is I'm directly seeing antibodies for Hashimoto's reduce way more often than not on GLP-1s. They're actually reversing Hashimoto's and getting people close to, if not into remission, which is pretty cool. I didn't expect that going into it, but it makes sense when we think about it from an inflammatory perspective. But the other two kind of categories that I'm seeing is, or a couple thoughts. One is as people lose weight, generally they need less thyroid medication. So you need to be checking in with your clinician for dosing adjustments reasonably often. But I'm also seeing two other big shifts. The most common one, and this affects hormones too for women in perimenopause, especially with GLP-1s, I consistently see an increase in sex hormone binding globulin, which makes your hormones less accessible. I haven't found that in the literature, but it is 100% of the time almost. So that changes the way that your thyroid medication is used and metabolized. And it kind of makes people, in essence, burn through their active thyroid medication more quickly. Like they need higher doses. They need a midday dose instead of morning, afternoon. That is the most common thing that I'm seeing. There is a subset of people too that I'm seeing maybe 5 to 8% of the time. I'm seeing significant absorption changes in thyroid medication, right? Because your food sits in your stomach longer. It competes for absorption with your thyroid. I do think we have to be a little more cautious for how long you wait after you eat or after you take your medication before you're eating. Separating meds from food for a longer period of time, at least an hour and a half after you eat before you take thyroid medication, or when you take thyroid medication, wait a full hour. Whereas normally I tell people you can eat 30 minutes later. It's not a big deal, but it kind of, in a subset of people, especially, it becomes a big deal on GLP-1s.
That's good to know. That, and also just a little bit of go backtrack. If you are on thyroid medication, whether it's again, a synthetic T4, or you're on a desiccated thyroid medication like myself, please give yourself that time. And I mean, in that, if you didn't know that you needed to wait, I'm always really mindful, especially my afternoon dose, about timing that accordingly, because I'm on morning dose and an afternoon dose. The morning dose is fine. I can do that just great. It's the afternoon dose you got to be a little bit more mindful of. It can be a little bit trickier. Okay. And then the other thing I wanted to ask, you were talking about once people are on this type of program, that there is a good chance, not only is it addressing metabolic dysfunction, right? Mm-hmm. That's what I like to call it. And that they're able to get off it and just live their life normally. Or do you find, you said, I guess there's like a distinction between, obviously you're on the program, you've got some goals that you're trying to hit, whether it's labs to move, like get them into optimal range, weight that you're trying to get to an ideal weight, energy, whatever that may be in terms of whatever your goals are. Then you can move to a maintenance dose, which is probably a smaller dosage. Maybe it's more extended out. Or do you find yourself in practice cycling people back in depending on what's going on with them?
Definitely it's tailored per person. Yeah. I would say the majority of people look for specific goals, a goal weight, B, metabolic numbers that show that they're going to be able to put in appropriate amounts of effort to maintain their weight in the future, meaning they don't need to over restrict, over exercise to maintain their weight, which most people that go into our program, that is the case. They're over restricting, over exercising, and they still can't influence their weight. Most people, I would say, get to that point. We wean them off reducing doses. And then sometimes I will transition them onto metformin for a while to
Mm-hmm.
maintain that metabolic potency and solidify it. And either long term they'll stay on that or they'll come off. The subset of people who tend to stay on these meds in our program are inflamed people. Like they have such a life changing experience with their levels of inflammation that they have not been able to solve. And that does not stay once you cycle off of a GLP-1. The inflammatory pathways that they influence are not going to, in a prolonged fashion, stay decreased. You're slowly going to regain some of that inflammation back. So those people tend to stay on microdoses. It takes microdoses to stay, on for anti-inflammatory effects down to like an eighth of the lowest dose. Even ever, I have people who do one injection a month and it maintains their anti-inflammatory effects, if that gives you some perspective. And then I certainly do have people that will cycle on and off, especially I think for women who have struggled with metabolic issues for so long that they start to have disordered thoughts around food. They start to beat themselves up around food. They start to feel guilty when they eat because they have not been able to influence their metabolism in appropriate ways for so long that there's almost a retraining in their brain that continues where food is not bad. Food is healthy. Food is fuel. My body is with me. It's not against me. And then, I think sometimes those pathways will play tricks on you and you'll start to look at food in a negative way again. And then they'll kind of cycle on it, retrain their brain around food a little bit, and then be able to come off for a year.
Okay, that makes sense. I really do appreciate that. And I think in this conversation, as anyone's listening right now, is that it is so nuanced. But I
It
wanted
is.
to give a kind of a very comprehensive perspective from your point of view, what someone should expect in this journey, because you're
Yeah.
absolutely right. I think people are just being sent it. They don't exactly know what they're taking. They're not understanding the dosage. They definitely have major side effects, and they think it's just par for the course. And so I really
Yeah.
wanted to work through kind of some of those nuanced scenarios that I'm seeing that I want to
Mhm.
discuss. I also know that in perimenopause with GLP-1 agonists, especially as we start to drop and decline in progesterone and estradiol, that can kind of play a role as well. So we're looking at hormone levels and working with a team that will look at that with you, I think is going to be important. Anything that you've noticed, like you said, if we start to see that binding globulin go up, that maybe we're not needing as much hormone as if we are using bioidentical hormones.
In the same way it influences thyroid, it influences reproductive hormones, right? And so it's like I could have a person stable on a testosterone dose for years, but if they go on a GLP-1, sometimes they need more testosterone because they take it and then it's used up and excreted quickly that they don't feel the impacts of it anymore. And even their level on labs drops. Like everything kind of globally drops. And imagine too, if you're not on hormone replacement, you're in perimenopause and you have borderline estrogen levels. Well, if you get on a GLP-1, it's very possible that GLP-1 will upregulate your estrogen utilization and drop it where you could experience symptoms of low estrogen more frequently than you did if you were not on a GLP-1.
I'm working through all the scenarios in my head. That makes so much sense to me as well. And if we're seeing something like that where we are just moving through these hormones, anything that I guess it's just looking at those hormone symptoms too.
It's so important. I mean, like, and I tell people, look, you might need support on the GLP-1, extra support for your thyroid, extra support for your progesterone. When you come off, you might not need that extra support anymore. Like those are times that are very sensitive and they are dynamic shifts. And people need to be tuned into those dynamic shifts and check labs that they can be addressed. And again, you're not just blindly moving through a weight loss program, having no idea what's going on globally in your body because so many things are impacted.
And then the last thing I want to ask in terms of lifestyle, we are taking something like a GLP-1 agonist. We're kind of just, we're really getting that full comprehensive support. I know there's, again, a lot of concern around loss of muscle. There's a lot of concern around not getting adequate nutrients. What are some lifestyle strategies that you're helping to implement to ensure that women are still hitting those goals, that they're not losing their muscle, that they're still staying resilient?
Totally. So obviously number one is do not over medicate yourself. Like do not let someone over medicate you. That's baseline because it's hard to circumvent that. But in addition to that, we get creative. Like the basics of exercise are, hey, we really don't want you doing a lot of cardio. We really want you doing a lot of strength training. We want you building muscle mass. Building muscle mass is perfectly attainable during these programs. Weight training and walking are kind of our two recommended forms of exercise. And then if you want to throw in a weighted vest for those in perimenopause to prevent osteoporosis, etc., bonus. But some tips and tricks for food that I really like to employ. The two things that I focus on are one, protein, two, micronutrients. These are the two areas that people lack on a GLP-1. The way that I recommend people do that is number one, you order your food for each meal and throughout the day. And what I mean by that is you start your day and your meals with protein. It is always protein first. That is your number one priority. After you eat protein, then you eat micronutrients, green leafy veggies, veggies of all different colors, antioxidants. And only when you've gotten enough of those two things do you eat carbs. Okay. Same throughout the day. Try and focus on protein and green leafy colorful veggies for breakfast, lunch, and then for dinner after you've eaten protein, veggies, then eat carbs. Save your carbs in the day. That also keeps your blood sugar as low as possible, as long as possible. And it allows you to eat more food. What happens with people, especially if they're over medicated, they crave carbs. Like they want to eat comfort food because they don't feel well. That's a good sign you're over medicated. You need to back off of your dose. You need to be able to eat protein and micronutrients. Another easy one that I have people do is green juice. Like if you want to get a lot of nutrients into one tiny serving, not a smoothie. A smoothie is a little veggies and still a large serving. If you do actual like cold pressed green juice, you get 6 or 8 pounds of veggies in 12 ounces of juice. And like the amount of space that occupies in your stomach is not a lot for an incredible amount of nutrients. So that's another tip that we routinely employ in our program as well.
I love that. I think that all makes sense. I will say that when I was on my GLP-1 protocol for my brain, I was suppressing too much. And I was only prioritizing protein and my lipids went out of range unfavorably, not crazy unfavorably, but I wasn't, all the fiber and the micronutrients that I was used to getting was gone. Like I was like, I only have room for one thing and it's a protein. And I saw my everything kind of move. This was a time where I was testing quarterly and I was like, oh, oops, like I'm all clean this up. And so I remember testing again it was like November and then January, and all of my lipids were back in range.
Right. And that's like the power of data. Like that's what I tell my people is like, we have so much data on you. If anything changes, we're going to know early on in the process. And you collecting all that data for so long, you knew, hey, this is shifting acutely in a 3-month period. Most people would never have a clue. They'd check it maybe once every year or two and see, oh gosh, my lipids are high. They wouldn't have any idea of the pattern and the cause. And that's why data is powerful. Like get you a clinician that will collect some data on you because you can harness it in very powerful ways.
I mean, you can make real-time changes. And I really love real-time data too. Again, you saw I have a CGM on at the moment and I have a Whoop strap on as well. I look at HRV every single morning. Well, throughout the day. I look at the stress monitor, body recovery, sleep, my sleep score, kind of what is the quality of my sleep. And then I'm looking at a continuous glucose monitor because I'm very curious as to what can I do in real time that's going to have an impact on my overall health and resilience. But then looking at labs, I look at labs at least twice a year, if not more, depending on what's going on. And it's amazing how much that data informs my lifestyle choices over time.
Absolutely. And I'll tell you, I mean, as a person that has collected a ton of data on me and my patients, whenever I wore a continuous glucose monitor for a few months, I was shocked at the things that I learned about it. Like I was shocked at how my blood sugar would conservatively rise, but I needed to go lay down. Like I was so tired. And I think there's so many pieces that until you really dig in and invest in your health, so many hacks that you could be missing that are super powerful.
I love it. Okay, honey, where can we find you? I mean, obviously you've been talking about Modern Thyroid Clinic, and I know that you guys are going basically within the US, you're going to be more available.
Modern Thyroid Clinic, we're expanding nationwide. We are, I think, in like 16 states at this point, and we're rolling out new states about every week or two still. So we'll be in 50 states in 2025, but we are also launching Modern Weight Loss, which is my new baby. Nationwide, we'll launch nationwide simultaneously. We think we'll have all 50 states covered in September of this year. And we are really trying to create a supportive environment for people who actually want to use GLP-1s in a way that is sustainable, promotes longevity, health, health. And we're excited to be able to do that. You can find me, at Modern Weight Loss, at Modern Thyroid online, but also at McCall McPherson on TikTok and McCall McPherson PA on Instagram. I love me some social and we hang out all the time there. So I hope to see you there.
Absolutely. Well, thank you, honey, for answering my barrage of questions today. And I just love you so much. And I just really appreciate your brilliance and what you're doing for so many women out there.
I know. Thanks for having this conversation. I love you back so much. And women need to hear this. They need more about perimenopause. My people especially have been asking me about it. So I'm glad we got to have this conversation. And I appreciate you and all the work that you pour into all of us women.
Thank you, honey. Thank you. Thank you. Thank you so much for watching. Now, if you found this video helpful, give it a thumbs up and share your thoughts in the comments. And if you are ready to learn more about perimenopause and how to navigate with a lot of ease and grace, be sure to subscribe to this channel so that you can join our community. Don't forget to share this video with someone that you love, that you know is navigating the perimenopause journey as well, because they deserve to feel their best too. See you in the next video.